Hello, and welcome to this presentation in which I'm going to take you on a journey through some of my research from 1983 to the present time. I started off doing experimental research and then moved more to observational and epidemiological research. So in this presentation, I'm going to share how my understanding of statistics has changed during this time. We can think of the research process in different ways. For example, we can conceptualize the research journey as developing your research strategy, developing your proposal, conducting the research, publishing your results, and considering the impact of those results. However, the research journey is often a bit more like this. It's often a messy, non-linear, and interactive process. While it's useful to chart a trajectory, be aware that the journal is not the same as the map. A major part of my journey has been learning about how statistics can be used to inform my research objectives, and this is something I'm going to explore in greater depth in future sessions. My PhD was on the control of movement in Parkinson's disease. Parkinson's disease is a progressive nervous system disorder that affects movement. Symptoms start gradually, sometimes starting with barely noticeable tremor in one hand. Tremors are common, but the disorder also causes stiffness or slowness of movement. So this was the topic that I was investigating, and I looked at a small group of patients with Parkinson's disease who were affected by tremor. So at this point, I wasn't really sure what role, if any, statistics would play in my PhD research. I think the first thing I became aware of was the need to develop a task in which I could study this experimentally, and that's what I spent quite a lot of time doing. What are the key measures that I was going to look at? How was I going to analyze the effect of tremor? At this point, I wasn't really aware of the need to think about whether I was going to be able to generalize from my particular observations to the overall population of people with Parkinson's disease. And my supervisor was a mathematician who believed in exerting as much experimental control as possible and not really using statistics at all. So eventually I developed a research paradigm that I'll talk about, and eventually I was able to publish a paper, and it describes in this abstract the type of analysis I did, which was Fourier analysis, which I'll mention, and also the theoretical framework which I used to interpret my results, which actually came from a very old paper which was nothing to do with Parkinson's disease, but I found it very useful in interpreting my results. So the first aim of my research was descriptive. It was to investigate in detail how and to what extent tremor interacts with voluntary repetitive movement. And as you'll see, I decided to look at a very simple task, which was finger tapping, because that made things more controllable. The second aim of the study was more experimental, which was to investigate the effect of tremor on bilateral tapping. The particular patient I looked at had tremor in one arm, but not the other arm, and I wanted to see how tremor would affect behavior. And so the reason for this was to gain further insight into the underlying neurological control mechanisms. These pictures here show the experimental setup that I had in those times. There were no PCs. This was a computer called a PDP-11, in which you basically had to write all your own programs. And I used this movement monitoring system here, which what you did was you put LEDs on different parts of the body, and they were recorded by cameras, and then you could analyze the data. This obviously shows not a Parkinson's disease patient, but a dog in which the researchers are analysing the movement. I chose, as you will see in a minute, a much simpler task because I knew that analysis of movement was a very complex topic. And the patients had to engage in a number of tasks involving finger tapping, sometimes to a metronome, sometimes in response to music. And I wanted to see how the left and the right fingers would behave in this setting. So my main subject was a 72-year-old male who was diagnosed as suffering from Parkinson's disease at the age of 63, and he had moderate tremor. And he didn't take his normal medication in the 24 hours prior to the experiment. His right hand was at all times unaffected by tremor. So in this way, he was able to serve as his own control. So the element of control is obviously important in all experimental studies, and again, that's something that we'll be looking at. This slide simply shows my not very good drawing of the experimental setup. You can see the patient sitting at a table, and he had to tap on these little brass plates here. The movement was recorded by the camera and sent to the computer for analysis. I'd like to look at one of the tasks that I did with the patient. In this task, the subject was required to tap at a rate specified by a metronome with either finger separately or together. And the metronome was set at different speeds, and importantly, the subject's eyes were opened or closed. In somebody without Parkinson's disease, it shouldn't really matter whether their eyes are open or closed, but we know that in Parkinson's disease, being able to see your hand actually helps you to perform the movement. So I wanted to investigate this in a bit more detail. And then also we stopped the metronome after a while to see whether they would be able to continue tapping at the speed specified by the metronome. Again, in a non-Parkinson patients, this wouldn't be a problem, but we wanted to see what would happen in somebody with Parkinson's disease. This shows the type of data that I was able to collect from this experiment. Here we can see the movement recorded and represented on a graph. Here we can see where the left finger is tapping, illustrated by the solid line, and we can see that compared to the right finger tapping, it's not as smooth because the tremor is interfering with the movement. This is the right finger without any tremor, and here we can see where the right and the left finger have to tap together. And just one key finding was that the tapping was actually not at the speed of the metronome, it was more close to the tremor frequency. So I think it's just worth saying here that I wasn't doing any statistical analysis at all. This was simply descriptive analysis, looking at the movement, and there was more conditions looking at the effects of perception as I mentioned earlier. What I discovered during my research was that there was a type of analysis that I could do to explore frequencies in more detail, and this method was called Fourier analysis. Fourier analysis is a method of defining waveforms in terms of trigonometric functions, and it's very useful in data analysis as it breaks down a signal into constituent frequencies. So I wrote a program to look at the tremor in more detail. So it's a form of statistical analysis. And here you can see that I'm comparing eyes open versus eyes closed. And with the eyes open, you can see that the person was able to tap much more in line with the metronome frequency. But when the eyes were closed, the movement became much more aligned to the tremor frequency. So it's a kind of statistical analysis, but it's not inferential statistics. This was only looking at the data from one subject. This slide further illustrates that there are lots of ways to represent data. This is taken from the book Medical Statistics at a Glance, and what it does is it summarizes obstetric data in women with bleeding disorders. First of all, we see a bar chart showing the percentage of women who require pain from these interventions during labour. Second of all, we see a pie chart, and this shows the percentage in the study with each type of bleeding disorder. Here we see a segmented column chart, women with different bleeding disorders who experiences bleeding gums, and we can see the frequency in the legend. This one shows a histogram showing the weight of birth, weight of baby at birth. Then we see a dot plot showing mother's age at birth with the median as the horizontal line. And finally, we see a scattergram showing the relationship between mother's age and the weight of their baby. So it's always worth thinking about the many different ways in which we can represent data, and I'll be looking at some further examples from my own research in a while. So we've looked at types of data, and it's important to understand your data and what question you're trying to answer. This is an example of some data from a study that I did in 1991. The topic was life events and psychological well-being in old age. Sometimes you need more complex statistics, and in this case I used a type of statistics called structural equation modelling. Structural equation modelling includes a diverse set of mathematical models and statistical models to fit networks of constructs to data. So I'm not going to go into the complexities of what I did, but you can see here the basic principles of the model that I was looking at. So here we have health events, non-health events, and these were measured by two different measures. And then we had psychological well-being, and we had different points of time. So we had time 1, time 2, time 3. I also had another set of variables that I was interested in, such as people's gender, social class, and so on. So whereas in the past slide we just looked at simple descriptive statistics, here we're trying to build a more complex model to represent the data. And this slide shows some of the results of the structural equation model that I was able to build. So you can see psychological state at the different time points, and you can see these coefficients representing pathways. And we have significant pathways and non-significant pathways. And paths can lead from different constructs, from psychological state to life events, and then from life events to psychological states. And we can also see the effect of social integration and so on. So I'm not going to go into the whole model, just point out one thing, that what I found was that life events are not random occurrences. Serious life events were often more reported by those with lower education, while women and those in lower social classes were more likely to have serious non-health events. Overall, long-term disruption directly attributable to life events were quite small when compared within the context of psychological state. So, although it's quite a complex model, the basic findings are that people's prior psychological state is quite robust, and the effect of health life events is relatively small. We can see the coefficients here, quite small compared to the coefficients for psychological state. Structural equation modelling was a technique I used again in 2004 when I was looking at problematic drug use among young people in Stoke-on-Trent accessing drug service. And you can see here the model that I was able to construct with level of problematic use related to all sorts of things, like, for example, the problems that people had before they began drug use. So this is just a schematic representation of the model. But you can see we had, from the questionnaire, we had many variables that potentially could have linked to levels of problematic drug use. So this was the hypothesis that we were exploring in the analysis. This is another way that I thought of representing the data from the analysis. What I did was I created an index of relative importance based on the regression coefficients and ranked the factors which seem to be related to levels of problematic drug use. So we can see many variables related to levels of problematic drug use. So I could have done that using just ordinary regression analysis, but I was also interested in the whole network of relationships back and forward between problematic drug use and these other factors. I'm now going to look at a 2012 study that I did entitled Preventing Opioid Overdoses in Europe, a critical assessment of known risk factors and preventative measures. And the way that I introduced the report was by looking at something else, which was people killed in road traffic accidents in Europe. And as we can see from the slide, simple descriptive statistics are enough to show us that there's been a decline over this period. The reduction in road traffic accidents in Europe has been linked to a variety of factors such as the use of seatbelts, enforcement of speed limits, prohibition of alcohol in excess of legal use while driving. So there seems to be a clear association between factors and the pattern of road traffic accidents that we see in Europe. Despite efforts to reduce drug-related deaths, we can see from this graph that the pattern of drug-related deaths in Europe is not as clear as that for road traffic accidents. We can see that there are times when it goes up and there are times when it goes down, but there's no clear trend. Clearly, drug-related fatalities is a complex issue, and there are many factors involved, and the efforts to reduce them have not been as successful perhaps as they have for road traffic accidents. So again, the point I'm making is just about the use of simple descriptive statistics to help us answer our research question. More recently, I've been studying polypharmacy. Polypharmacy is an expression that's been commonly used for many years in medicine. It is generally understood as referring to the concurrent use of multiple medications by one individual. Polypharmacy may be harmful in that it can increase the risk of drug interactions, together with impairing medicine adherence and quality of life. On the other hand, employing many appropriate treatments can improve outcomes for patients. However, the evidence base for multiple interventions for several conditions in a patient is poor. And this was a study I did using the English longitudinal study of aging, using data from about 7,000 people. And again, I'm only going to show you a small part of the analysis. And what I did was to present to the reader bivariate correlations between various factors and polypharmacy. And although the text is a little bit small here, we can see the factors listed, such as long-standing conditions, poor self-rated health, being an older age, having a higher BMI, lower wealth. These are all things which are positively associated with increasing polypharmacy. And you can see the strengths of the association shown by the bivariate correlation. So quite a simple measure. And later on in the study, I constructed a more complex model, but I wanted to show the reader factors that were associated just at the outset with polypharmacy. And perhaps more surprisingly, we see down here that people who smoke and people who consume higher levels of alcohol were less likely to have polypharmacy. And this is something I talk about elsewhere in the paper. These are the findings from another study that I did using the ELSA dataset. And this time what I was looking at was the relationship between alcohol consumption and health state. In particular, does alcohol consumption at one point in time predict future health many years later? And here we can see the data. Again, very simple data, looking at different categories of drinking, always being a non-drinker, people who'd stopped drinking, low-risk drinking, hazardous drinking, and high-risk drinking. These are the government's definitions of risk associated with alcohol. And the bar shows the proportion of those in poor self-rated health. So you might expect higher alcohol consumption would be associated with a higher level of this bar, which is poor self-rated health. But in fact, as you can see, this isn't really what we see. We see the highest rates of poor self-rated health associated with people who never drank and people who stopped drinking. And if we look at the data many years later, we don't find that people who reported high levels of alcohol consumption in 2002 had higher rates of poor self-rated health many years later. And I discussed these findings in this article here. And the way I summarized it was that our research reports that older people who drink substantially more than the recommended guidelines have just as good health as those who drink below the limits. Alcohol consumption at baseline, above or below the recommended guidelines, did not predict future health. The group with the worst long-rated health were those who never drank alcohol. And the way that I interpreted this in the paper was that on the face of it, these findings seem extraordinary and seem to defy both the scientific evidence and common sense. After all, there is extensive research linking alcohol consumption to a range of illness. And a study published in The Lancet ranked alcohol as the most harmful drug ahead of heroin and crack cocaine. So again, some simple descriptive data from the ELSA study, perhaps casting a new light on this topic. In the article, I also look at another factor, which is the association between wealth and self-rated health. So along the bottom, we have each group of drinkers divided into those in low and high levels of health. And what we can see is that wealth has a major association with poor self-rated health, irrespective of the level of alcohol consumption. So the graph shows that for all drinking patterns, those with higher wealth reported much lower levels of poor self-rated health than those with lower wealth. Now I'm going to look at a 2009 study that I did looking at the relationship between cannabis use and schizophrenia. For many years, there's been concern about the possible effects of cannabis consumption on schizophrenia. And this was something that the government asked me to look at, specifically the government's advisory committee on the misuse of drugs. And that's because of work that I've been doing using the general practice research database, which is a very large database of millions of patients, which contains all their medical records, including whether they've been diagnosed with schizophrenia. The point was there didn't seem to be any data available around this time, 2009, on what the trends in schizophrenia were. So how could we know whether cannabis was causing a change in the pattern? So my study didn't actually look at cannabis at all. It only looked at rates of schizophrenia. And the reason why I'm presenting you this graph is just to show you that what I did was calculate rates per 100,000 PYE, which is person years of exposure. In other words, I took all the time that was available on the general practice database from when people were first registered with their practice, and I looked at the number of times whether they'd had a diagnosis of psychosis or schizophrenia, and also whether they'd had a new diagnosis. So that's the distinction between prevalence, which is current cases, and incidence, which is new cases. And what this graph shows here is the prevalence of schizophrenia and psychosis over a 10-year period. And the key point really was what's the trend? So we don't really need any complex statistics to investigate that. So what the conclusion was that the study did not really find any evidence of increasing schizophrenia or psychosis. As we can see over the time period, it's fairly stable or perhaps even declining. So the fact that there had been high levels of cannabis use in the years preceding this study it had been hypothesized that this might be leading to increased schizophrenia. And this is just one element of the jigsaw. It doesn't answer the question specifically, but it's a part of the jigsaw which helps us to make sense of this association. This slide is taken from a 2018 study that I did on metabolic health. Metabolic health is having ideal levels of blood sugar, triglycerides, HDL cholesterol, blood pressure, and waist circumference. These factors directly relate to a person's risk for heart disease, diabetes, and stroke. This study was concerned with the relationship between metabolic health and depression. In introduction to the paper, we note that conflicting results have been reported when the associations between metabolic health, obesity, and depression were examined. So the aim of this study was to determine whether metabolic health or obesity are independently associated with depressive symptoms among a representative sample of older people living in England. And what we did was we used logistic regression to look at whether a range of factors were independently associated with depressive symptoms at 2-year follow-up using unadjusted and adjusted odds ratios. So again, a type of statistical model which is designed to look at a range of factors and how they relate to an outcome. Here we see the outcome, which is the odds ratio, and we see the 95% confidence interval with the p-value. And we begin just by looking at metabolic health, and we can see it looks on the surface that there is an association between metabolic health, not very strong, but slightly increased risk of having depression. When we adjust for obesity, this goes down slightly. When we adjust for other factors such as gender, age, and wealth, it also goes down. In fact, it's no longer statistically significant. So again, we have this issue of how do we relate the statistics to our understanding of the data? Because what we see here is a slightly increased risk, but one that's not statistically significant when we control for other factors. So again, it's not the last word in the story, but it's adding to our understanding of the relationship between these factors. And when we look at it from a slightly different perspective, this time looking at the effect of obesity on depression, and again we see a stronger association, odds ratio of 1.54, meaning that people who classified as obese were 54% more likely to be depressed. But when we adjusted for a range of other factors, it's no longer statistically significant. So again, using the data set to explore something which, although it had been the subject of previous research, we were able to add more factors into the equation, including looking at baseline depression. So not giving a clear definitive answer, but suggesting perhaps that obesity and metabolic health may not be associated with depression. And as we've seen before in other studies that I've talked about, wealth is an extremely potent factor in relation to health. My final example comes from a 2017 paper in which I reported the use of a method called conjoint analysis. Conjoint analysis is a type of research method that mimics the choices that we make when we make a decision to buy something, for example, buying a phone or a car. In this case, what we were concerned with was using this method to understand individuals' treatments for osteoarthritis. And I'll just show you some of the features of the study. So a series of screens get presented to the participant in the study. In this screen, it says, please think about the medication that you would most like to take for osteoarthritis. For each feature, select your preferred level. And then you can see there are several features, availability of the drug, and which for each feature there are different categories. So for example, for availability, there are prescription drug, over-the-counter drug, or an internet purchase. For the frequency of the drug, we have once a day, twice a day, etc. And then, for example, another important feature is how much benefit do you expect? Do you expect 25% benefit, 50% benefit, or 75% benefit? And then there's a series of side effects. And once you've gone through this, a computer program then generates a series of scenarios. And as it says here, for each column represents one drug. For each one, please indicate if you would consider taking this drug. So you have to weigh a basket of attributes, and you go through a series of these, and the computer program works out your preferences. And what we did on this slide is portray the results for two participants, participant 1 and participant 3. And the way that we portrayed it was to standardize the values for the different attributes that we were thinking of. So when you have different measures, you can standardize them all so they have a mean of 0 and a standard deviation of 1, assuming that they're normally distributed. And again, this is just a way of presenting complex data in a way that is understandable to the reader. And I'll just go through the two graphs. So these case studies indicate individual preferences. Participants' one priority was the avoidance of the 4 high-risk side effects. So we can see that there are high values for avoidance of the side effects. Here we have heart attack and stroke, kidney and liver, stomach side effects and addiction. So you see these high values deviating from the value of 0 means that these are all important things that the participant 1 is concerned with avoiding. And you can see that the other attributes are actually not very important at all. You might think that, for example, expecting benefit would be an important attribute, but for this particular individual, it's not really very important. In fact, less than 10% of what you might consider their overall importance is accounted for by these characteristics here. Participant 3 is similar. We can see the importance of avoidance of the side effects, but very important for this person was the fact that the drug would be available on prescription. So we can see, and these are just two examples, the individual choice profiles can be very complicated, and this is just a way of, when you have complex information, finding a way of presenting it to the reader that they can understand your findings. And so I'm going to return to this slide, which I used at the start of the presentation to illustrate the research journey. As you can see, my research journey has involved many different types of research, so it's kind of probably more in line with this complex pathway here. And I've just tried to show you during this presentation some of the ways that I've learned to understand, to analyze and present data. So I hope you will find this useful in considering your own research.